Hello everyone, welcome to windy Chicago. It's a pleasure to be doing the ACP broadcasts again, and I'm really pleased to bring today Pippa Corrie, Paul Lurigan and Paul Nathan, who many of you will know. We're going to focus on melanoma today, and there's been some really exciting data coming out of ASCO, and I hope you're going to find this a really exciting session.
I'm delighted to be able to present to you some fabulous data that was shown today, which represents a genuine quantum leap in the treatment of melanoma and probably a variety of other cancers as well. And this study is an immunotherapy study combining two immunotherapeutic drugs, ipilimumab, which is an anti-CTLA-4 antibody, and nivolumab, which is an anti-PD-1 antibody, and both the targets for these drugs are involved in inhibiting immune expansion and activation. And by inhibiting both these two targets, you can expand the immune repertoire to have a potent anti-tumor benefit. This is a complicated study with 7 cohorts of patients with advanced melanoma. We're going to concentrate on the first 3 cohorts in which there was a dose-finding regime looking at different doses of ipilimumab and nivolumab, and we'll particularly concentrate on cohort 2, which culminated in being the recommended phase 2 dose of ipilimumab at 3 milligrams per kilogram and nivolumab at 1 milligram per kilogram. The ipilimumab is given every 3 weeks, and nivolumab is given fortnightly. So here are the results for the first 3 cohorts, and we're going to concentrate on cohort 2, which was the effectively recommended phase 2 dose with 3 milligrams of ipilimumab per kilogram and 1 milligram of nivolumab per kilogram. So a total of 17 patients were treated in this cohort, and you can see that 9 out of the 17, in other words 53%, had a RECIST-defined response, and 3 of these patients had a complete response, which is an 18% complete response rate. As well as this high response rate, what was remarkable was that all of these 9 patients had at least an 80% reduction in their tumor burden at the first scan, which is has been referred to as a deep response. And these data are best illustrated with these graphs, and these are the patient volume graphs in spidergram and waterfall charts for all 3 cohorts that I've mentioned at differing doses. So on the left, with the spidergram, you can see that the vast majority of patients had a rapid shrinkage in their tumor burden, and you can see that most of those shrinkages were up to 80% or more. And that shrinkage happened within the period of the first scan. The other thing that we can see, which has been described with immunotherapies before, is there are a couple of patients whose disease was growing but then shrank. And again, if you look at the waterfall plot, which is the change in tumor burden per patient, the data are shown again. In conclusion, the combination of ipilimumab and nivolumab has resulted in a remarkably high response rate, and interestingly, many of these patients had a deep response with dramatic tumor shrinkage with a volume reduction of at least 80%. Because these are immunotherapeutics, this raises the possibility that these patients will have long-term durable disease control, which is extremely exciting. And it's certainly not an overstatement to say that this is the most exciting advance with immunotherapy probably ever in the history of oncology, and will radically change clinical practice, not just for melanoma, but for a variety of other cancers as well. So, Paul, what do you think about those data?
Well, I think they're absolutely fascinating. I think as you said, the most exciting development we've seen in immuno-oncology ever. I think it's got huge implications for how we treat melanoma and other cancers. I think, as you pointed out, the high response rate of over 50% and the depth of response, the majority of patients getting more than 80% tumor shrinkage and responding very quickly. And so the response profile is similar to that we've seen for targeted therapies with vemurafenib. And but we would never have expected to see that with an immunotherapy combination. So very exciting, very provocative for the future, but early data really, and we need more follow-up, and but very exciting.
Sure. Absolutely. Pippa, so we're fortunate now with melanoma to have two strategies, and we don't quite yet know how complementary they are, one with immunotherapeutics and the other with targeted BRAF and MEK agents, and potentially others coming through. Where do you see the field going in terms of how to optimally use these two strategies?
I think it really does challenge the way the field has been moving over the last 2 years. We've spent a lot of time reorganising the way we manage our patients to stratify by BRAF status, and this is suggesting that we need to rethink that, and immunotherapy may become the first line treatment for all of our patients, particularly if we do see that long-term durable benefit. So I think we do need the longer term data. We do need to confirm that that is the case, because that will be the difference. If we're seeing the same response rates, how long is that durable for? So I suspect this is going to become our first line treatment, and our targeted therapies may move behind. We'll see.
Yes, I would agree with that, and I think that until now our sort of philosophy had been to try and get patients into remission with a targeted therapy and consolidate that with immunotherapy. That had been a sort of a concept, and I think that this turns it completely on its head, and because of the rapidity of the response and the depth of response, that we'll be treating patients up front. And of course, we're not limited to one particular group of patients, unlike with targeted therapies where it's selected based on mutation testing. So it's a treatment that should be suitable for all.
In terms of biomarkers and being able to predict which patients have most benefit, what are your feelings?
Yeah, so I mean, again, it was very interesting that there'd been some previous suggestion that the PD-L1 expression may actually be able to define the patient group likely to benefit. But what was clear from the data was that the lack of expression of PD-L1 did not mean that you would not respond to this treatment. So again, at the moment, we don't necessarily have a biomarker, but it may not be so relevant right now. So we'll see.
Yeah, and finally, one of the questioners in the auditorium today asked whether we need a large phase 3 study to confirm such a remarkable response. What do you think about that?
I mean, I would definitely agree. I think we do need to see the longer term data. We need to see confirmation in a larger patient cohort. We can learn a lot more from that large number of patients, hopefully collect some samples for some translational work to underpin the clinical data. But I think it is still a relatively small study with very short follow-up. So.
Yes, I mean, I think, remembering back to with vemurafenib and the excitement around the phase 1, phase 2 studies, and we learned a huge amount from the BRIM-3 study about long-term treatment of patients with targeted agents. But having said that, I think what we don't want to be doing is treating a lot of patients who don't get an opportunity to access the combination. I think that the study design needs to be smart, the endpoints need to be realistic, and there will probably need to be crossover in that study, because we risk prejudicing the outcomes for patients if we don't have that.
So AVAST-M is a UK NCRI melanoma clinical studies group trial. It's based on the hypothesis generated by Judah Folkman, who described an angiogenic switch required to induce tumour growth, invasion and metastasis. And it was suggested that inhibition of VEGF, a key promoter of angiogenesis, might reverse that switch and therefore inhibit tumour progression. Several clinical trials have been conducted with adjuvant bevacizumab in the context of colon and breast cancer, but these haven't shown a significant clinical benefit. We designed a randomized trial to evaluate the role of adjuvant bevacizumab in patients at high risk of melanoma recurrence. In this trial, we used stratification variables of tumor primary melanoma breast lobe thickness, ulceration, end stage and gender. And patients were randomized to receive bevacizumab, 7.5 milligrams per kilogram intravenously every 3 weeks for up to 1 year, or to an observation arm. And patients are being followed up for 10 years or until death. The primary endpoint chosen for this trial was overall survival. Secondary endpoints were disease-free interval, distant metastasis-free interval, safety and toxicity, and quality of life. In addition, tumour samples and blood have been collected for predictive and prognostic biomarker analyses. The primary outcome measure, overall survival, is shown here in the Kaplan-Meier curves, and they show that the treatment arm and the observation arm have similar outcomes. So the 1-year overall survival rate was 95% in both arms, and the 2-year overall survival rate 82% in both arms. The hazard ratio was 0.97 and the p-value 0.76. A key secondary endpoint, disease-free interval, did show a significant difference between the two arms. So the yellow curve shows the treatment arm doing better than the observation arm, with 1-year disease-free interval rate of 77% for bevacizumab and 70% for observation. At 2 years, the disease-free interval rate was 59% for bevacizumab and 57% for observation. The hazard ratio was 0.83 and the p-value 0.03. Finally, the distant metastasis-free interval curves are quite similar in shape to the disease-free interval, although the benefit for the treatment arm is not clinically significant here. The 1-year distant metastasis-free interval rate was 85% for bevacizumab and 70% for observation. And at 2 years, the DMFI rate was similar in both arms, or the same in both arms, 69%. The hazard ratio was 0.88 and the p-value 0.18. Bevacizumab monotherapy was extremely well tolerated in this patient group. Grade 3/4 adverse events occurred in 15% of the bevacizumab-treated patients and 5% of observation arm patients. The most common adverse drug reaction was hypertension. Grade 3/4 hypertension occurred in about 6% of bevacizumab-treated patients. And there was 1 patient death in the treatment arm. That patient had a cardiac history and developed a hemopericardium. And the role of bevacizumab is not entirely certain in that situation, but couldn't be excluded as being implicated. So what is the impact of AVAST-M in the adjuvant setting? The most recent interferon meta-analysis of over 7,804 patients, combining a series of interferon trials of a variety of different doses, has generated a hazard ratio for disease recurrence of 0.85 and a hazard ratio for overall survival of 0.91. The hazard ratio for disease-free interval for the AVAST-M trial of 0.83 is comparable to that of adjuvant interferon. We're now awaiting the results of 2 other key adjuvant trials, the EORTC 18071 trial of adjuvant ipilimumab and the GSK-sponsored DERMA trial of the MAGE-A3 vaccine. And taken together, these trials will really determine what the optimal treatment strategy should be for adjuvant therapy, particularly in the wild-type setting.
Pippa, congratulations on an excellent presentation. And it was an important study for the UK that recruited really well, and
Yes.
it showed that we can recruit to large adjuvant studies very effectively. So well done, and I know all of my colleagues around the country feel the same. So it raises some interesting questions. I mean, first of all, not just in melanoma but in other tumour types as well, the role of anti-angiogenic treatments as an adjuvant is interesting, because there's a conceptual issue about how you can, whether or not you need the presence of the anti-angiogenic constantly to stop a micrometastasis growing. In other words, do you ever reach a point where you can withdraw the treatment? What do you think AVAST-M does for that sort of hypothesis?
I think that's right. I think it is an interesting one. If you look at particularly the colon cancer data, I think the argument there was very strongly that you need the agent there to maintain the inhibition constantly to see an effect. I think it's still quite early for us. This is an early pre-planned interim analysis. But if you look at the shape of the curves, actually in that first year of treatment, there is a separation and they do come together in the second year. However, after that, they separate again. Now, the events in the later parts of the curve are small in number, and I think we will need to follow that quite closely and see whether actually the same issue is there for melanoma. Melanoma is not the same disease as some of these epithelial cancers in which the concept has been tested so far. Obviously, we also have a large bank of tissue and blood, and we may be able to tease out some of the issues of the biology through the translational work that we need to start to do.
So Paul, I mean, I assume that if we're hypothesising that if that separation after 2 years is real, and obviously there's an issue about events, presumably one's looking at a mechanism that's distinct from an anti-angiogenic mechanism, because that's after the drug's been withdrawn. Are you hypothesising that there's some sort of other phenomenon?
That's a good question. I mean, I think that the use of bevacizumab in this situation was, for the reasons that Pippa has said, was that there was, as expected, this angiogenic shift, and otherwise the cells become dormant. They remain in that they can't progress through a certain size because they get their oxygen and nutrients by diffusion, and so that you're getting that prolonged effect by treating the patients when they're at their highest risk of recurrence. And these were high-risk patients, and we would normally expect that the highest risk of recurrence is within the first 3 years, but a rather precipitous recurrence often within the first 6 to 12 months. And so that treating them when the cells are most likely to grow, when they're also at the most vulnerable, and that has a long-lasting effect. I suppose that's the take-home message.
Yeah.
And I guess there would also be the possibility that you could be having an immune effect as well.
Yeah, well, absolutely. And bevacizumab has an effect on the immune system, well-known effect on the immune system. And we've seen with other agents, targeted agents, where long-term benefit probably comes from having some effect on the immune system, not the actual direct effect of the targeted therapy. So absolutely. Yeah.
So I don't think we can look at one mechanism in isolation. It's probably multiple
No, and I think
parameters.
the point you made that we've got a huge tumour bank now, tissue bank of both tumour and blood to look at these, to look at prognostic and predictive factors and to examine those. And that's a huge resource. And you could, at the meeting, you could see those things, there was sort of palpable excitement about that.
Yes,
absolutely.
Yeah, that's good.
So there's a big buzz about melanoma, obviously, for a number of reasons, with BRAF and MEK targeted agents, and also immunotherapies with ipilimumab and a variety of anti-PD-1 and PD-L1 agents in development, all of which one expects will be looked at in the adjuvant setting. Obviously, the IPI data we're waiting for, and a variety of other studies are underway. So against that background, I mean, how do you feel about where the potential for adjuvant bevacizumab would be? Is there a subset of patients you think would be a candidate for treatment with adjuvant bevacizumab? Or?
So I think that's something that we need to start to look at. We have taken a preliminary look at some subgroups and identified that it may be that there are certain groups that may, for example, not benefit. And there seemed to be some suggestion that the stage 2 patients and ulcerated primary tumours don't appear to benefit. Now, if you turn that round, you could say, well, maybe this is a treatment for those patients that do have lymph node involvement. Whether that's enough to say we should be offering that treatment to those patients, I think is too premature. But I think it's giving us clues of where to look next. So I think we need to understand. We need to wait on the results of the current trials. Obviously, there's another trial which is just starting up in particularly the primary ulcerated tumours run by the EORTC, looking at pegylated interferon. And so it may be that there will be different strategies for different cohorts of patients. So I think it's open to conjecture at the moment. I don't think the data is strong enough for us to have changed practice, but I think it's a foot in the door to suggest that there are alternative treatments and treatment options for the future.
The next two studies are both using molecularly targeted agents in a population of patients who have mutations of BRAF, which, as many of you will know, occurs in approximately 50% of cutaneous melanoma patients. The first study has been presented by Mark Middleton, and this was a study using the AstraZeneca MEK inhibitor called selumetinib. Selumetinib is an interesting drug. It was looked at in a large randomized phase 2 study compared with dacarbazine in an unselected population of melanoma patients a few years ago. And it showed actually disappointing activity, although there was evidence that the handful of patients who had benefit from selumetinib in that study were far more likely to have benefit if they contained disease that carried a mutation in the BRAF oncogene. This study looked at the combination of selumetinib with dacarbazine compared to dacarbazine on its own, again in a population of patients who had metastatic melanoma carrying the mutation in BRAF. The primary endpoint was overall survival, secondary endpoints, progression-free survival, objective response rate, safety and tolerability. Overall, 385 patients were screened and only 91 were randomized, and most of that fall-off was probably because of patients who failed screening due to failure of BRAF testing. This is the results, and you can see on the top line for overall survival there was a trend in favor for overall survival of the combination of selumetinib with dacarbazine compared to dacarbazine on its own, of 13.9 months compared to 10.5 months. It didn't reach statistical significance with a hazard ratio of 0.93 and a p-value of 0.38. For progression-free survival, there was a statistically significant benefit in favor of the combination of selumetinib with dacarbazine of 5.6 months compared to 3 months, hazard ratio of 0.63 and a p-value of 0.021. So the drug in combination, the MEK inhibitor in combination with dacarbazine, was significantly more active than with dacarbazine on its own. Unsurprisingly, there was also an increase in adverse event profile of the combination therapy, with 36% adverse events leading to hospitalization with the combination compared to 13% of dacarbazine on its own. And the most frequent AEs associated with the combination were those that we know are commonly associated with MEK inhibition, particularly skin problems, but also some diarrhea, nausea and vomiting. So the key message from this study was that there was clinical activity in patients who had BRAF mutation-positive melanoma treated with the MEK inhibitor selumetinib in combination with dacarbazine, reflected by an improvement in progression-free survival and a non-statistically significant improvement in overall survival. And the feeling was that the tolerability of the combination was consistent with previous safety profiles and is clinically manageable. The second study is an interesting study looking at the combination of both BRAF and MEK inhibitors together, so the combination of dabrafenib and trametinib, both made by GSK, looking at two different groups of melanoma patients, those who have previously failed BRAF inhibitors and those who have not previously been exposed to BRAF inhibitors. And this is an analysis of a larger, more complex study, elements of which have been looked at previously. The novel part of this study is actually the activity of the combination in the group of patients who previously have had single-agent BRAF inhibitors and now in this study have gone on to receive the combination of dabrafenib and trametinib. So the primary endpoints were complete response and partial response, and the secondary endpoints progression-free survival. And if you look at, first of all, the BRAF naive group on the right-hand side of this table, and you can see, looking at the treatment groups, the combinations of full-dose dabrafenib and trametinib, the progression-free survival for joint BRAF and MEK inhibition together was 10.8 and 9.4 months, with an overall response rate of between 60 to 76%, and a median duration of response of 10.5 to nearly 11.5 months. And that replicates the data that was presented by Georgina Long at last year's ESMO meeting. In the BRAF inhibitor resistant population, so the population of patients who'd previously had treatment with a BRAF inhibitor, the combination was disappointing, and there was only a progression-free survival of 3.6 months and an overall response rate of between 9 to 15%. And the take-home message really from this is that despite the combination of BRAF and MEK inhibition being very active in a treatment-naive population of patients who have metastatic melanoma which carries BRAF mutations, in a group of patients who had previously had BRAF inhibition, BRAF inhibitors, the combination is not clinically significantly active. And I think that summary slide says pretty much that.
So two very interesting studies. The second one, I think, answers a very important clinical question, and the first, the selumetinib study, gives us an indication of where to go in a certain group of melanoma patients, I think. So Pippa, just with the selumetinib study, could I ask you just to tell us a bit, to put it in context, like when was the study done, and how do you think the data stack up against, you know, vemurafenib, which is currently licensed, and dabrafenib, as we know, has just been licensed in by the FDA?
Yeah. So I think it is tricky. This trial was obviously started quite a long time ago, when the vemurafenib work was only just beginning. And the trial that Paul alluded to had been undertaken. It was one of the first trials looking at a targeted agent in melanoma, and caused quite a stir when they identified that subgroup of patients with BRAF mutation where there might be some additional activity. So the rationale was there, was very solid, very sensible to take that forward. It has taken quite a long time for this trial to come to fruition. And obviously events have overtaken us to some extent. So it's still very interesting. Clearly what's very important is that although BRAF targeted agents are very much the main interest now, we know that resistance is inevitable. So we need to have other options for these patients. Would you agree?
Yeah, no, absolutely. And then just moving on from that then, Paul, I mean, I wouldn't expect that you'd be recommending dacarbazine plus selumetinib for your patients with the BRAF mutation now, but is there any group of patients that you think we might be worth looking at that combination in?
I think, as Pippa said, the issue is that we do have more active single agents for that group of patients with BRAF inhibitors, and potentially with a superior MEK inhibitor, trametinib. I think the issue for me is that you could combine selumetinib with chemotherapy. And although it may be, or it is, a less potent MEK inhibitor than trametinib, that may allow it to be more combinable with a variety of different agents. And so I wouldn't be too put off from thinking about future alternative combinations with selumetinib, because it might be possible that MEK inhibitor is more easy to combine with a variety of other agents than trametinib.
And as we know, the MAP kinase pathway is activated in the majority of patients with melanoma, and BRAF, of course, mutations occur in about 50%, but NRAS mutations occur in about 20%. So what do you think about looking at the combination in that group of patients?
Yeah, I think we need options for them, and it would be sensible. What did you think about the side effect profile, though? It was suggested that it was tolerable, but there was an amazing proportion of patients who were hospitalised.
Yes, I think that may have been a learning curve, I think, to do with it.
So.
I think that would be an element. In terms of NRAS, I think there is surprisingly unattractive data with trametinib with the NRAS mutant population. Single agent.
Yeah.
And so although there's a cartoon schema rationale of thinking that a MEK inhibitor with an NRAS mutant tumour may be active, So far, as a single agent, it's not that attractive.
No, but I think your comment on combination, so combination with chemotherapy, that might actually be, a useful combination to look at for those very reasons.
Yes. So I have a question for you. So dabrafenib and trametinib are both, as you say, licensed.
Yeah.
In the US a few days ago, and they're both licensed for V600 mutant tumours, and trametinib is licensed for patients who have not received a prior BRAF inhibitor. So if you had free access to both agents, how would you use them?
I think dabrafenib and trametinib are licensed now, but the main expectation is that we'll be using the combination very soon. And as you know, we've just completed 2 big randomized studies comparing combination versus BRAF inhibitors. And our impression is that the response rates are higher and the progression-free survival is much improved. And I think that is what we're going to be using within the next year or so. How we bridge to that, I'm not quite sure. I think dabrafenib certainly a very appealing data in brain metastases. The toxicity profile is slightly different to vemurafenib. But I don't think there'll be a dramatic change in practice until the combination comes along. And then we will, of course, have to go through the funding process in the UK. Yes. And I think that we may well find that we actually keep our powder dry and go for the combination. So then moving on to the combination study, and it was a complex design, and it was hard to pick out the data. But the bottom line from that, I think, was, so it was looking at the combination study that, as you say, was published in New England Journal of Medicine recently. And what I hadn't fully picked up in at the time was there were a population of patients in that study who had had prior BRAF inhibitors, and I think we've learned a lesson from that. And just what do you think that is?
Well, that getting a continuing response in disease that's become resistant to BRAF inhibitors is going to be very difficult, and that's perhaps partly because of the multiple resistance mechanisms that the tumours use, and interesting data that not just multiple resistance mechanisms between patients, but within a patient as well.
Yeah.
And I thought what came out in the discussion today at the ASCO meeting was the importance of trying to collect patient samples to try and answer the biology. And it's difficult to do this kind of stuff on tissue. That's where we really do need liquid biomarkers and liquid assays that we can do so that we can answer questions in individual patients.
A practical question, patients who you have on vemurafenib will often ask you when they progress, can I have the combination?
Yeah.
Should we offer it to them based on these data?
Not anymore. I probably would have done previously.
Yes, I think that's the take-home message. It's answered an important question for us. We can fairly categorically say. In the discussion, actually, they weren't quite as firm about it, and they said, well, if the patients had a long benefit from vemurafenib, then they may benefit from the combination, but otherwise, the answer was no, and you should be looking at other treatments. So, yes, 2 very important studies. I think we've learned a lot from them. Yeah. And a good meeting for the NCRI Melanoma CSG, 2 important studies.
Absolutely.
Absolutely.
Great contribution across the country.